Hello and welcome to this recording of Chapter 25, Fluid, Electrolyte, and Acid-Base Balance in the Fundamentals textbook. The two largest constituents of body fluids are water and electrolytes. Water is present in greater proportion than electrolytes are. Water serves many functions, but the four main functions of water in the body are to act as a vehicle for the transportation of substances to and from the cells, to aid in heat regulation by providing perspiration, to assist in maintenance of hydrogen balance in the body, and to serve as a medium for the enzymatic action of digestion. More than half of the body's weight is water. The amount varies by age, sex, and health status. The infant and the older adult are affected more quickly and seriously by minor changes in their fluid balance and can become rapidly dehydrated. The older adult has an age-related decline in total body water, and the infant's kidneys are not as efficient as the adult's, and less fluid is reabsorbed. These factors will cause dehydration to occur more quickly in the younger adult. Dehydration can cause hypovolemia. Water is critical to maintaining homeostasis because water is the medium in which most metabolic and chemical reactions in the body take place. Water is the avenue for transportation within the body. It carries nutrients to the cells and transports waste for excretion. Electrolytes are minerals or salts that are dissolved in body fluid. They are measured in milliequivalents per liter, MEQ per L, which is a unit of measure of the chemical activity that occurs when the electrolyte reacts with hydrogen. When in a solution, electrolytes will break up into particles, known as ions, and have a tiny electrical charge. The ions will develop positive electrical charge and are then known as cations, or they can develop a negative electrical charge and are known as anions. For each positively charged cation in a fluid compartment, there must be a negatively charged anion so that the balance is maintained. As fluids move from compartment to compartment, the body works to maintain homeostasis in each compartment by balancing the anions and the cations so that there is electrical neutrality. The major source of electrolytes is our diet. The intermediate products of metabolism are amino acids, which are proteins, glucose, and fatty acids. These are our non-electrolytes. Go back and look at page 446, table 25.2, the major electrolytes. This is going to show you the normal range and function of the major electrolytes that our body needs to function: sodium, potassium, calcium, magnesium, phosphate, chloride, and bicarbonate. Now, the non-electrolytes, which we will know as amino acids, proteins, glucose, and fatty acids. In the healthy individual who is eating normally, the non-electrolytes circulating in the body fluid will remain stable. The body has 4 to 6 liters of circulating blood volume, depending on your body size and sex. Any condition that alters body fluid volume and also alters the plasma volume of the blood will affect blood pressure and circulation. Body fluids are either intracellular within the cell or extracellular outside of the cell. Extracellular fluid can be of 3 types: intravascular, interstitial, and transcellular. When fluid shifts out of the plasma in the vascular space out into the interstitial space, blood volume drops and dehydration or hypovolemia will occur. Let's look at table 25.3 on page 447. Extracellular fluid makes up 1/3 of the total body water. It transports water, nutrients, oxygen, and waste to and from the cells. Intravascular fluid is fluid within the blood vessels. It consists of plasma and fluid within blood cells. Transcellular fluid includes aqueous humor, saliva, cerebrospinal, pleural, peritoneal, synovial, and pericardial fluids within our body. This also includes our gastrointestinal secretions and fluid in the urinary system and lymphatic system. The amount of fluid leaving the body should be balanced by the water entering it. The thirst mechanism located in the hypothalamus will help control fluid balance in the body. It monitors fluid volume and concentration. Fluid is lost in the urine and feces through invisible losses or insensible losses. This is via exhaled air and through our skin as perspiration. The kidney is the main organ through which fluid excretion is achieved. Urine output is affected by several hormones, particularly ADH, aldosterone, and ANP. ADH, we know, is secreted by the posterior pituitary. More ADH is released when the blood becomes more concentrated. The circulating blood volume is decreased, or the person is experiencing pain, nausea, or stress. With increased ADH, the renal tubules will reabsorb more water, and the urine output will decrease. Aldosterone is released by the adrenal cortex when the ECF volume is low or when the sodium concentration is decreased. Aldosterone will cause reabsorption of sodium from the kidney tubules, resulting in more water retained. ANP acts to protect the body from fluid overload, and it is released from sites in the myocardium and the brain. Blood volume and blood pressure will also affect glomerular filtration rate and our urine output. Water and substances must move through a semi-permeable membrane and out of the body cells in order to function. As the blood flows through our capillaries, fluid and solutes will move into the interstitial spaces, and that is where substances in every cell of the body can be exchanged. Diffusion is the movement of particles from an area of higher concentration to an area of lower concentration. Glucose, oxygen, carbon dioxide, water, and other small ions and molecules will move by diffusion. This is a process of equalization. Many intracellular proteins have a negative charge, and that tends to attract positively charged sodium and potassium ions from the extracellular fluid. Osmosis is the movement of liquids or solvent across a membrane. In our body, water diffuses by osmosis. Water and other body fluids will move from an area of less solute concentration to an area of greater concentration until the solutions in both compartments are of equal concentration. Cell wall membranes are semipermeable, as are the walls of the blood vessels. When living cells are surrounded by a solution that has the same concentration of particles, the water concentration of the intracellular fluid and the extracellular fluid will be equal. This type of solution is called isotonic, which means of equal solute concentration. If cells are surrounded by a solution that has a greater concentration of solute than the cells have, the water in the cells moves to the more concentrated solution, and the cells dehydrate and shrink. This solution is called hypertonic, of greater concentration in relation to the cells. If the cells are surrounded by a solution that has less solute than the cells have, then that solution is termed hypotonic. The particles within these cells will exert an osmotic pressure, drawing water inward through the semipermeable membrane. It will do this until the cells swell from the extra fluid, and they can even burst. These concepts are more important to the administration of IV fluids. By osmosis, water passes freely across all cell membranes. Osmotic pressure within the cells will also help keep fluid from leaking out into interstitial spaces. Filtration is also known as capillary filtration, and it's the movement of water and suspended substances outward through a semipermeable membrane in response to a pressure. The pumping action of the heart will create hydrostatic pressure, and this hydrostatic pressure causes fluid to press outward on the vessel. This force will promote filtration, forcing movement of water and electrolytes through the capillary wall and to the interstitial fluid. Active transport requires cellular energy. This force can move molecules into cells regardless of their electrical charge or the concentrations already present in the cell. Active transport can move substances from an area of lower concentration to an area of higher concentration. It does this using adenosine triphosphate, or ATP. Active transport can move amino acids, glucose, iron, hydrogen, sodium, potassium, and calcium through a cell membrane. The healthy kidney will regulate fluid and electrolyte balance by regulating the volume and composition of the extracellular fluid. Any disease that affects circulation, including heart failure, will ultimately affect the distribution and composition of our body fluids. In fact, any serious ill patient is at risk for fluid and electrolyte imbalance. A fluid imbalance will exist when the body has an excess, too much, or a deficit, too little, of water. When this occurs, there will be an accompanying imbalance of the substances dissolved in the water. Water always follows sodium within our body. The sodium concentration causes an osmotic pull, and water will go to where that concentration is the highest. Those at risk for a fluid volume deficit includes patients who are unable to take in sufficient quantities of fluid due to impaired swallowing, extreme weakness, disorientation, coma, or the unavailability of water. Patients who lose excessive amounts of fluid through prolonged vomiting, diarrhea, hemorrhage, diaphoresis, or excessive wound drainage. Dehydration is treated by fluid administration, either orally or intravenously. This test, a test of tissue turgor, can be assessed by gently pinching upon the skin over the abdomen, forearm, sternum, forehead, or thigh. This test will measure skin elasticity as well, and it's not always a valid indication of fluid loss in older adults and infants. On page 449, in box 25.1, we can see some signs and symptoms of dehydration, also known as fluid volume deficit. When people become ill, they may take in more water than they excrete. This can happen if they receive IV fluids too quickly, are given tap water enemas, or are persuaded to drink more fluids than they can eliminate. Impaired elimination, like occurs in kidney failure, is an important cause of fluid volume overload. Signs of overhydration are weight gain, crackles in the lungs, slow bounding pulse, elevated blood pressure, and possibly edema. When fluid volume overload occurs, hypervolemia, excessive blood volume, can also occur. Hypervolemia will cause an elevation in blood pressure. Edema is an excessive accumulation of interstitial fluid. This is often a sign of fluid overload, but it can be due to other causes. In ambulatory patients, the excessive fluid will tend to accumulate in the lower extremities. In the bedridden patient, the fluid will accumulate in the sacral region. These types of fluid accumulations can be called dependent edema. Treatment will involve correcting the underlying cause and assisting the body to rebalance the fluid content. Hyponatremia is a deficit of sodium in the blood. This occurs when the sodium level is less than 135 milliequivalents per liter. Sodium loss can occur from excessive vomiting or diarrhea when the fluid loss is replaced with plain water. Hyponatremia can cause mental confusion, headache, altered level of consciousness, anxiety, coma, anorexia, nausea, vomiting, muscle cramps, seizures, and decreased sensation in the body. On pages 451, 452, and 453, you can also see in table 25.4 the different electrolyte imbalances, some signs and symptoms, causes and risk factors, as well as some nursing interventions. Hypernatremia is when the serum sodium concentration rises above 145 milliequivalents per liter. A state of hypernatremia will exist when there is an excess of sodium or a loss of body water. Decreased water intake can occur in the immobile, confused, or dependent patient, or in those who have sustained damage to the thirst center in the hypothalamus. Hypokalemia occurs when the potassium level falls below 3.5 milliequivalents per liter. Hypokalemia can be a result of malnutrition, illness causing a shift of potassium from the ECF to the ICF, or increased potassium loss. Vomiting, diarrhea, and prolonged gastrointestinal suction can also deplete potassium levels. The patient is encouraged to eat foods high in potassium, and IV replacement may be necessary with hypokalemia. Hyperkalemia is when the serum potassium level rises above 5.0 milliequivalents per liter. This can occur in patients with kidney failure, severe burns, or crush injuries, as well as those undergoing major surgery. Hypocalcemia occurs when the calcium level drops below 8.4 milligrams per deciliter. This can result from nutritional deficiency of calcium or vitamin D. Hypocalcemia occurs in disorders in which there is a shift of calcium into the bone. Hypercalcemia occurs when a serum calcium level is above 10.6 milligrams per deciliter. This can occur during periods of lengthy immobilization when calcium is mobilized from the bone or when an excess of calcium or vitamin D is taken into the body. Hypomagnesemia, it's hard to say that one, is a serum level below 1.3 milliequivalents per liter. This can result from numerous situations, including decreased magnesium intake from starvation, malabsorption, or alcohol use disorder, as well as pancreatitis and gastrointestinal losses from diarrhea, vomiting, or gastric suction. Hypermagnesemia is a serum level above 2.1 milliequivalents per liter. This occurs rarely and is usually in the presence of kidney failure. Anion imbalances can also occur with imbalances of chloride, phosphate, and bicarbonate. These can accompany other cation imbalances because of the principle of electroneutrality. Hypochloremia is a chloride level below 96 milliequivalents per liter. This is associated typically with hyponatremia, but it can also occur with severe vomiting and can be seen as a compensatory decrease in acid-base disorders. Hyperchloremia is a chloride level above 106 milliequivalents per liter. This will occur along with hypernatremia and a form of metabolic acidosis. Hypophosphatemia will occur when the level of phosphate falls below 3.0 milligrams per deciliter, and hyperphosphatemia will occur with a phosphate level above 4.5 milligrams per deciliter. This can be commonly seen with kidney failure. Acid-base balance is very important to maintaining homeostasis in the body. pH is a measure to the degree of which a solution is acidic or alkaline. The concentration of hydrogen ions will determine the pH reading. A normal serum pH is 7.35 to 7.45. Bicarbonate is an important substance in maintaining acid-base balance. The normal range of bicarbonate is 22 to 26 milliequivalents per liter. Bicarbonate acts as a buffer to neutralize the excess acids in the body and maintain the bicarbonate to carbonic acid ratio at 20 to 1. This is needed for homeostasis. For the serum pH to remain within the normal range of 7.35 to 7.45, the ratio of bicarbonate ion to carbonic ion must be 20 to 1. There are 3 control mechanisms for pH. The first is the blood buffer system, which consists of weak acids and weak bases. When a base is added to the blood, it combines with the acid component of the buffer to form a weaker base. This will minimize pH changes but it does not remove acids or bases from the body. The second control mechanism for pH is the lungs. The carbon dioxide and water are expired for the lungs, decreasing the amount of acid in the body. The third control mechanism for pH is the urinary system. The kidneys will reduce the acid content of the serum by exchanging hydrogen for sodium with the help of aldosterone, and the kidneys can neutralize acids by combining them with ammonia and other chemicals. There are 4 types of acid-base imbalances. To determine if an acid-base imbalance exists, the pH, arterial carbon dioxide partial pressure, or PaCO2, and bicarbonate ions are measured by arterial blood gas analysis, performed on a sample of arterial blood. An increase in hydrogen ions results in acidosis, which is a decrease in pH. A decrease in hydrogen ions can result in alkalosis, which is an increase in pH. An initial change in carbon dioxide is nearly always the result of a respiratory disorder. When an imbalance occurs, the lungs and kidneys will try to compensate by working to bring the pH back to a normal limit. Respiratory acidosis will occur when carbon dioxide levels increase. This can occur with a variety of disorders, including acute problems such as airway obstruction, pneumonia, asthma, or chest injuries. Chronic respiratory acidosis is prevalent among people with chronic obstructive pulmonary disease, or COPD. This can also be known as chronic airflow limitation, or CAL. Respiratory acidosis is very commonly due to COPD. This is also evidenced on page 456 in table 25.5 that goes over acid-base imbalance causes, signs and symptoms, and the typical arterial blood gas values that you would expect to see. Metabolic acidosis is an excessive loss of bicarbonate ions or an increased production or retention of hydrogen ions. Metabolic acidosis can also occur when large amounts of acid are produced within the body. Acidosis can depress the nervous system. This can cause a headache, lethargy, weakness, and confusion. Respiratory alkalosis can occur due to hyperventilation. This is a rapid respiratory rate. Treatment for hyperventilation is to treat the underlying disorder. The person may breathe through a rebreather mask temporarily, mixing the excessively exhaled carbon dioxide with oxygen so that the carbon dioxide is inhaled. Metabolic acidosis can most commonly be caused by diuretic administration. Vomiting and gastrointestinal suction can also result in the loss of hydrochloric acid from the stomach, as well as excessive antacid consumption, which can cause metabolic acidosis. Effects of alkalosis will include irritability of the nervous system. Tetany is characterized by severe muscle cramps, carpopedal spasms, laryngeal spasms, and stridor. This can occur as alkalosis progresses. For a patient with fluid and electrolyte or acid-base imbalance, we first must assess the patient for any type of imbalance present, then assess for any physical signs and symptoms of alterations in their normal balance. Evaluate intake and output records to determine whether or not there is any imbalance. The urine volume of an adult should usually be 1,500 mL in 24 hours. Urine-specific gravity will normally range between 1.003 and 1.030. Tracking daily weight is another way to assess for alterations in fluid balance. See the assignment considerations on page 458 in the purple box. When assessing the measurement of daily weight, remind the unlicensed assistive personnel that the weight needs to be measured at the same time every morning with the patient in the same clothing on the same scale, after they have voided and before they have eaten. Otherwise, an accurate measurement of weight gain or loss will not be possible. Ask the UAP to report any change of more than 1 kilogram immediately. A weight gain or loss of 1 kilogram in 24 hours will indicate a weight gain or loss of 1 liter of fluid. Skin turgor, which is the elastic condition, is partially dependent on the amount of tissue fluid supporting the skin. Edema can be an indicator of fluid volume overload. Look for puffy eyelids and swollen hands. Edema can sometimes be evidenced by a pit or indentation that develops when a fingertip is pressed into the tissue over a bony prominence, such as the malleolus or tibia, and held for 5 seconds. This is known as pitting edema. Changes in vital signs are pertinent when assessing fluid, electrolyte, and acid imbalance. A fever can cause increased fluid losses. Pulse rate greater than 100 beats per minute can be an early sign of decreased vascular volume from fluid volume deficit. Imbalances in sodium will have direct effects on brain volume and mental function. Neuromuscular irritability can be assessed when imbalances in calcium and magnesium are present. Chvostek's sign is assessed by tapping the facial nerve about an inch from the earlobe. A twitching of the face would be considered a positive response. To test for Trousseau's sign, place a blood pressure cuff on the arm and inflate it above the patient's systolic for 3 minutes. A spasm of the hand would indicate a positive sign. When planning, collaboration with the patient and family or caregiver will allow the best plan to be devised. Priorities of care should be set, and the goal is to restore the patient's fluid, electrolyte, or acid-base imbalance. A specific time frame should be incorporated into the expected outcome. If patients can swallow and retain their fluid, frequently assist them with taking in small amounts of fluid. Look at their meal tray before it's removed from the room and record the intake of the shift on the intake and output record. Record all amounts in milliliters. IV fluid infused is recorded as intake. At the beginning of the shift during the handoff report, note how much is left in the IV container that is in progress. Another IV container may be started during the shift when the old one is completely infused. By adding and subtracting, you can calculate the total amount of IV intake. For example, suppose that a patient has 350 milliliters remaining in the IV bag at the beginning of your shift. It finishes, and you hang a new bag at 1 p.m. At the end of the shift, 200 ml has infused from the new bag that you hung. Add 350 and 200 for a total of 550 mLs of IV intake for your entire shift. Enter this amount on the intake and output record as intake under the IV column. Fluid output is of course also counted and recorded. To measure urine output, pour the urine from the bedpan or urinal into a graduated container. Always wear gloves whenever handling any type of urine. Place the container on a flat surface and read the level of fluid at the eye level. On page 461 in table 25.8, you can see some common equivalents of food containers from containers into milliliters that can be very helpful whenever calculating milliliter volumes from a patient's tray. Output from all other sources should of course be measured, including drainage from a nasogastric tube, chest tubes, wound and drainage suction devices. Emesis should also be measured and always recorded as output. The patient with a fluid volume overload may have an order for fluid restriction. This means that they may only have a certain amount of fluid over a 24-hour period. It's important to work out a schedule of fluid intake so that liquids are spaced out evenly and the patient does not receive all of their allotted liquids in a short time. A typical schedule would be day 600 mLs, evening 400 mLs, and night 200 mLs. If not prohibited, hard candies and chewing gum can help relieve thirst. Frequent oral care is essential. Daily weight and electrolyte status must be monitored along with intake and output for these patients. Skin care is particularly important in preventing breakdown over an edematous area. Always be gentle in repositioning and turning your patient to avoid friction on their skin. Use a lift sheet. A break in edematous skin can quickly form a pressure injury. The patient with fluid volume overload may be placed on a sodium restriction because sodium is usually retained along with water. Monitor laboratory values for electrolytes and acid-base balance to determine whether treatment is effective and the imbalances are being corrected. Assessment for fluid balance will be ongoing. Monitor their adherence to the sodium restriction by periodically rechecking the patient's food intake. Every 24 hours, you should perform evaluation to see whether your nursing interventions are helping the patient meet the expected outcomes.